Speaking about hemodynamic aspects in the 21st century, perhaps we can call it today and tomorrow. I was pleased to hear that people re-emphasize the importance to move up from poorly characterized patient populations towards precision medicine, and in between, I would say personalized medicine. I think we have enough of big trials trying to target mortality in ICU patients or in patients with SIRS or with sepsis. All these trials have been negative when they target mortality. But we are still facing patients, and we need to personalize our approaches. We cannot have the same reactions all the time. Patient is hypertensive, give some fluid. Oliguri, give some fluid. Tachycardia, give some fluid. We know there is this type of U-curve. Of course, we want to avoid hypovolemia that could result in altered tissue perfusion, but we don't want our patients to be too edematous either, because the organs do not like to be edematous. And actually, too often, we navigate between the two. Some people today would like to have minimal monitoring, and they want to have liberal fluid administration that may result in major edema. But I have seen also some people using a very minimal monitoring and restrictive fluid administration with a lot of patients with renal failure. And I have seen recently even a patient with splanchnic ischemia and GI bleeding, something that we no longer see in ICU patients. But this patient had no edema because the physicians had restricted fluid tremendously. And we know that keeping the patient on hypovolemia, on vasopressors, that's the road to multiple organ failure. That's really what we want to avoid. And yet, people would like to simplify this difficult problem. If you look in anesthesia, I found it sad to see this study on restrictive versus liberal fluid therapy for major abdominal surgery. Why would you restrict fluids? And this ended up with more renal failure and more surgical site infections. It's not the type of trial that we need. We need to give adequate fluid administration, and this requires monitoring. Someone already alluded to this study from Providence, a restricted IV fluid trial in severe sepsis and septic shock. Patients were randomized to get reasonable amount of fluid or restrictive fluids. There was no difference in outcome globally, but you can see that hopefully some patients were shifted from the restrictive fluid strategy group to the other group. But what kind of monitoring? Read the methods of this method section. There is nothing on monitoring. We don't know. We don't know how fluids was given. So at the end, in the best case scenario, when there is no difference in outcome in not well-defined patient populations, there are patients who may benefit from more IV fluid, but some patients who may be harmed. And in the other arm, there may be patients who also benefit from less IV fluid or may be harmed because they would be hypovolemic. So just speaking about fluid restriction, I think, is not a good idea. because fluid restriction will always reduce edema, but it may decrease oxygen availability to the cells, it may impair healing, and it may result in multiple organ failure. We sometimes say that we should give fluids to try to correct hypovolemia. I think it's too simple, because our patients are often vasodilated under the influence of many mediators. So they need actually to have more fluids than the amount of fluids required to return to normovolemia. And there may be capillary leaks, of course, with some edema formation. That will be unavoidable. And at the end, we often want to have a hyperkinetic state, in particular in sepsis or in trauma or after major surgery. So we can look at a dichotomy, if you like. Should we give fluids by formula, or should we individualize the fluid administration? And for instance, for the septic patients with the surviving sepsis campaign, we actually balanced between the two. The two were recommended. Some people still like to give formula. How much fluid should I give? And this was the guideline I didn't like at all. Give 30 cc's per kilogram in 3 hours. In 3 hours! Do you know where you will be in 3 hours? It's such a long period of time. You can go in a resuscitation room, you can tell the resident you have not given enough fluids. Well, the patient has been here for 2 hours and a half. I still have 30 minutes to go. No. But my colleagues who are really keen on applying evidence-based medicine told me, Jean-Louis, we have only evidence for 3 hours. I said, you know, we can still think, we can still be good doctors. And finally, they agreed and they say, well, okay, we will do 1 hour bundles. They are hardly better because it just says you can begin fluid administration in 1 hour. And then comes a lactate more than 4. I don't know where it comes from. People should talk to each other when in the next room there is a discussion on trauma. In the field of trauma, we have abandoned the golden hour. We ask it, is it dogma or medical folklore? And then people emphasize that we waste time by looking at a 1 hour time interval. So patients may deteriorate before that, and the golden hour policy has been clearly revisited. So I like this recent paper, well, not so recent, but this paper saying that there is the golden hour and the platinum 10. I give you 10 minutes. I give you 10 minutes to give fluids, to check lactate, and to prepare for vasopressor therapy. You don't have 1 hour. So in sepsis, the golden hour, it is too long to start when we need to put in place. And beyond that, just referring to time may be too arbitrary because some patients may be stabilized early, some patients may need more time. That's how we recommended to follow the 4 stages in the resuscitation of the acutely ill patient. Salvage, okay, that's maybe 10 minutes, half an hour. You don't have much monitoring system. You just give fluid, vasopressors, you try to save life. But then you need the second phase of optimization, individualization of the patient's needs. We should not miss the stabilization phase because then we should stop giving more fluid. We should try to hold on and wait before there is a de-escalation phase where hopefully the patient will urinate, edema will disappear, and vasoactive agents will be discontinued. So that's individualization of care. And indeed, with the Surviving Sepsis campaign, we also mentioned that fluid should be guided by frequent reassessment of the hemodynamic status. Now, what do you mean? It's still a tough question because people will emphasize we should not target a given central venous pressure, or arterial pressure may not tell us if the patient needs fluid or not. Tachycardia is very aspecific. The cardiac output does not tell you much. Urine output, maybe the patient needs fluids, maybe not. We will speak about SVO2 and lactate in a moment. So, yeah, again, it's not easy. We don't want our patients to be very edematous. We would like to give fluids to increase flow, and if there is hypotension, to correct it, and to decrease heart rate, increase urine output, improve organ perfusion. But we don't like edema. We don't like to induce edema. We would like to minimize edema formation. So we are back to the basic Frank-Starling relationship. Every patient is represented by a dot and is on his own or her own Frank-Starling curve. So if the filling pressure is very low, the patient is likely to respond to fluids, but otherwise, it's hard to guess. We don't know. So we will have to try. We would like to maximize benefit, but limit harm. So how could we do? Again, basing our initial strategy on physiology, if the patient is on fully controlled mechanical ventilation, we could actually look at pulse pressure variation during the respiratory cycle or the stroke volume variation during the respiratory cycle. The idea is that during invasive mechanical ventilation, the cyclic changes in intrathoracic pressures will be transmitted into the ejection of blood by the left ventricle, and therefore we will see on the arterial pressure curve that the patient is indeed preload dependent. There will be fluctuations in pulse pressure if the patient has an arterial catheter in place, or fluctuations in stroke volume if we use a monitoring system like the PICO, for instance. It just indicates that the patient is on the ascending limb of the Frank-Starling relationship. Of course, there is a gray zone. It's not always clear-cut. Maybe we should not really focus on one single number, but it could help us in these patients who are mechanically ventilated and not triggering the respirator. It works very well in anesthesia, in the operating room. And here with Alexandre Josten, a young, dynamic anesthesiologist in Brussels, we could even show that actually an application could be used from your smartphone, and you could take a picture of the arterial pressure trace, and this could give you right away the pulse pressure variation of the patient. So during anesthesia, it works very well, of course, when the patient is in sinus rhythm. But otherwise, if you look at all studies, including ours, these patients were all profoundly sedated and even paralyzed when we did the study on these signs of fluid responsiveness. But today we try not to sedate our patients, so it's hardly applicable in ICU patients today. In any case, if we do not find these signs of fluid responsiveness, it would be a clue to stop giving fluids. And that's a very important element. I will return to that in just a moment. Could we look at the echography of the inferior vena cava during the respiratory cycle? It doesn't work very well. In some studies, it did go well when you look at the what we call the rock curves, when the point is up to the upper left corner of this scheme, of this graph. It's good, but you can see that sometimes it's like flipping a coin. Or we could go via the superior vena cava by transesophageal echo. Well, this group of investigators did it. It's a very nice study, well done. But the area under the curve is not very good, and these patients were sedated and paralyzed for this. So it's not so simple, I'm afraid. We could perhaps, as proposed by the group in Paris, use an increase in tidal volume to stimulate the system, but lung recruitment may interfere with it. It could be a limitation of this test. So at the end of the day, for patients who are breathing spontaneously, it could be mechanically ventilated, but breathing spontaneously, we need to test the system. We need a dynamic evaluation. And of course, the classical aspect is the fluid challenge. It's a dynamic approach. We give fluids and we see how the patient responds. Again, we hope there will be an increase in cardiac output. We hope there will be minimal increase in cardiac filling. And with the Surviving Sepsis campaign, it's the first recommendation for the amount of fluids. A fluid challenge technique be applied where fluid administration is continued as long as hemodynamic factors continue to improve. That's my first challenge. What is a fluid challenge? Give 500 cc's of whatever? No. Give 500 cc's in 30 minutes? No, because there are too many things that could happen in 30 minutes. In 10 minutes? Well, it's not a fluid challenge yet. We need to give a small amount in 10 minutes. Well, 200 milliliters, you may argue, is not such a small amount, but it's a limited amount. And assess the patient's response. Yeah, that's exactly right. So let's look then at skin perfusion. We talked about the evaluation, capillary refill time. If we want to be straightforward, we could look at changes in cardiac output by the technique we like. And by echo, we could assess it, maybe not very precisely, but well enough. In the operating room, where things can change very rapidly, we could even propose a mini fluid challenge over just a few minutes, or even 1 minute in some studies. This is a recent one where they used 100 cc's in a very short period of time in the operating room. So, if we give it over a too short period of time, maybe every patient may have an increase in cardiac output. But if we wait for too long, well, first, the effect may be too small, and there may be some other elements that may influence cardiac output. So ultimately, 5 to 10 minutes, that's good. And the amount of fluids should be not more than 100 to 200 cc's in 5-10 minutes that we could potentially repeat. Fluid challenge today and tomorrow. TROL, type of fluids, rate of infusion, I just spoke about it, the clinical objective, the safety limits. This could be done automatically. I think we will see systems being developed where it will be done automatically. And that may be a good advance. How many patients will respond? Sometimes people say, only 50% of the patient will respond. But that's the idea. That's why we call it a challenge. 50% of patients will respond, 50% of patients will not respond, and if we see that the patient does not respond, we should stop it. These are the guidelines for management of children and neonates in septic shock, and they recommend to start by giving a fluid bolus and evaluate the patient's response. But even in these children and neonates, they say, I was not part of the group, I'm not really a pediatrician, but they say that monitoring filling pressures can be helpful. So you look at changes in arterial pressure versus changes in central venous pressure. Well, it could be smart to do an internal fluid challenge. That is a passive leg raising test. That's smart. We could change the bed's position and we could evaluate the changes in stroke volume during the test. If the patient is not sedated, the problem is that it is stressful. The patient really wants to know what's going on. So it sounds easy. I just raise the legs. But what do you do? Exactly. Tell me. It's not just looking at blood pressure. You need to have a tool to monitor stroke volume over a few beats because it's very transient. So it's not so easy. It sounds easy. It's not so easy. But speaking about today and tomorrow, I return to my little piece on intensive care medicine in 2050 with Dr. Slutsky and Gattinoni. Our child now says, when I was in shock, I was told that the bed was kept moving to assess how much fluid I needed while my cardiac response was monitored by all the probes. There was even a closed-loop system driven by a computer that continued to deliver fluid challenges as long as my cardiac output was responsive, combining it with titration of vasopressor and inotropic agents. That's the future. So the patient may actually be taken around in the bed while the hemodynamic assessment is indeed performed. Another big element in the future is that transthoracic echocardiography will be done with very small probes, very thin probes. So it will be very comfortable for the patient to keep it. And then we will see the images at the bedside as we enter the room. It will be a continuous monitoring of cardiac size and function. Again, if the patient does not respond to fluids, we should stop giving fluids. The other aspect of the future is the early identification of even minor hypovolemia. I was very impressed by a recent visit at the military hospital in San Antonio, and they showed me this, and they said, this is a tool to simulate hypovolemia by inducing a negative pressure in the lower part of the body. So in volunteers, you can simulate a hypovolemia. And by using just a modern system of plethysmography around the finger, they can identify even mild hypovolemia before tachycardia occurs, before cardiac output falls. There are ways to identify minor degrees of hypovolemia very early. And I think we will use this type of tools in the future, and the technology will help us to better identify hypovolemia. Pump. We touched on that a bit earlier. When I was younger in the field, we were writing in our papers what we used to do, which is that vasopressor support is added when hypotension persists despite fluid administration. We have seen it many times. Try fluids first. If it doesn't work, add vasopressors. No. Why would you wait? If the patient does not respond to fluids, why would you allow the patient to remain hypotensive for a while? No. Give norepinephrine right away. Try to decrease the doses and to discontinue the norepinephrine if possible. But avoid the hypotensive phase that could alter organ function. Even if the patient responds well to fluids, well, try to avoid this transient phase. And this is one of the papers coming from China, actually, emphasizing that, the early use of vasopressors in severe hypotension may limit the severity of organ dysfunction. This is another paper showing the same thing. And more recently, we saw from large databases that any hypotension lasting just for a little bit is associated with more renal failure and actually more mortality. So it's not just severity of the hypotension, it is the duration. We just published this paper from the MIMIC3 database, a database that everybody can have access to from Boston. And we could also show that hypotension lasting less than 2 hours can be associated with a worse outcome. And it's even worse when it lasts longer. As it was mentioned before, a paper from Thailand just came out where patients were randomized for early norepinephrine or not. Okay, shock was stabilized earlier with the early administration of norepinephrine, but there was no difference in blood pressure, as you can see, at least for the first hours, and no difference in fluids administered. So I don't think it really helps very much. But the concept is there. My former teacher, Dr. Weil, used to say every patient is a VIP. Oxygen, mechanical ventilation if needed, fluids, pump, vasopressors, maybe inotropic agents, VIP. I always keep it in mind when I go to a resuscitation room and when there is a lot of noise around. Keep it simple, VIP. So which blood pressure target? Well, initially, in septic shock, let's say, it should be 65. People dropped the word initially. They say, oh, septic shock, 65, 65. Initially! And then we say, and I love it, if initiated, vasopressor dosing should be titrated to an endpoint reflecting perfusion. It should be individualized. Have you seen this study? It's all so sad. Why do you want to randomize patients in septic shock for a higher or somewhat lower blood pressure? Of course, there is no difference in mortality. Some patients need a somewhat higher blood pressure, and some others are very happy with a somewhat lower blood pressure. But of course, patients having a history of hypertension may require a higher blood pressure than the others. When I was a student, my teachers were telling me, there is an autoregulation curve, and patients who are chronically hypertensive may need a higher blood pressure than the others. Atherosclerosis, the same thing. So why can't we individualize our therapies based on a careful clinical evaluation? What about skin perfusion, consciousness, etc., SVO2 lactate? So that's my second challenge, the vasopressor challenge. And then the third one is oxygen delivery. When we want to increase oxygen delivery, we have 6 options. But once hypoxemia is corrected, patients are usually tachycardic, they may be somewhat hypotensive. So we have 3 options: fluids, transfusions, and dobutamine. Dr. Rivers, in the classical study in 2001, showed that if you keep the SVO2, the saturation of the venous blood in the superior vena cava, at 70%, which is the normal value, by giving more dobutamine, more transfusions, more fluids, you may actually reduce mortality rate. Okay, it's a study 18 years ago. There have been 3 prospective randomized controlled trials since then showing no difference in survival. But these patients all had, at least they had a mean value of 70, 71, 73%. So in the River study, the SVO2 was much lower than in the more recent studies. Maybe the world has changed. Okay, I accept that. But we still see some patients with a low SVO2 following resuscitation. So the prospective randomized control trials had problems because these patients were not very ill. Some went home after the initial resuscitation, or they went to the regular floor. They were not very sick. So if sometimes we see a patient with a low SVO2, we can still think at giving more fluids if we can still do it. Give a transfusion if there is anemia. I won't give a hemoglobin level because we need to think a little bit about this. There is no very clear-cut value. And perhaps a little bit of dobutamine, especially if there are signs of myocardial depression. So that's how we proposed recently to go from early goal-directed therapy to later SVO2 checks. If the patient does not improve, let's check it. And if the SVO2 is low, that would be an indication for something that can increase oxygen delivery a bit further. If you like to go even one step further, you can look at veno-arterial PCO2 gradients, because sometimes the SVO2 is actually in the normal range, but this gradient may be increased, suggesting that oxygen delivery is not sufficient yet. So if the delta PCO2 exceeds 6 millimeters of mercury, that could be a clue to still further increase oxygen delivery. So we can summarize: fluid challenge, cardiac output, filling pressures, low SVO2, vasopressor challenge, all of this. Only in septic shock, but this is my third challenge. A little bit of dobutamine may sometimes help to restore tissue perfusion. When the patient is very vasoconstricted under noradrenaline, we need to relieve that. We cannot go on and increase the doses of norepinephrine further and further. So we see again that cardiac output measurement can be helpful, but not alone. They need to combine with other variables. Now, in the future, of course, artificial intelligence will help. This is a beautiful paper, complex to read, on artificial intelligence in the management of sepsis in the ICU, evaluating how the patients responded to fluids and vasopressors. And with machine learning, this artificial intelligence system could show that the doctor sometimes is giving too much fluid and sometimes not enough vasopressors, or the other way around. And so this could be a way to go. I think we will have these systems in the future, not to replace the team, no, but to suggest, to raise the possibility of giving more fluids, or stopping giving fluids, or giving more vasopressors or not. In the future, we will be, of course, less invasive. Of course, there is no doubt about this. We will try to find better markers of cellular happiness. Right now, it's lactate with all the limitations. We know that one single lactate measurement may not give the answer, and we may repeat the measurements over time, something which is easily done now with the simple instruments we have in the ICUs. And actually, it's one of my first publications 30 years ago. We looked at how fast the lactate levels will go down in the best case scenario when the patient responds to fluids right away. And we found it's only 10% in 1 hour. 10% of decrease in lactate in 1 hour. So could it guide resuscitation? I would say no, it's too slow. And we reviewed the literature on this, and it's open access if you like to look at it. We hope that when the lactate level is high, it will go down. We hope that the lactate level will never increase again. Some people call it lactate clearance. It's not clearance. But we found that, indeed, measuring lactate levels every hour, every 2 hours is okay. So it's not something that will guide therapy. It's something that will tell us whether we are in the right direction or not. If we see that there is a clinical improvement, but if there is no decrease in blood lactate levels, we may be too optimistic. Maybe cells are not so happy after all. Or if we don't find a clinical improvement, but if lactate levels go down, maybe we are pessimistic, and perhaps things are actually getting better. Now, of course, nothing is perfect. I wouldn't say that lactate levels can replace everything. But if the lactate levels are increased, let's consider that there is indeed an alteration in tissue perfusion. Some people try to combine lactate and SVO2, but that's not a very good idea, because SVO2 can change rapidly. You give a little bit of dobutamine, the SVO2 will increase right away, whereas lactate levels will decrease. The decreased lactate level will be much lower. You may think that there may be a washout period from underperfused regions. It's probably not a major thing. Dr. Weil here in animals showed that with resuscitation after cardiac arrest, the worst form of shock, there is hardly any blib, there is hardly any small increase in lactate levels shortly after resuscitation. So present and future, I think we will do more on the regular floor. Hopefully we can count on nurses on the floor that are often at the patient's bedside, that can recognize organ dysfunction. And that's how today we really act. I was member of this consensus panel. We developed the quick SOFA. I'm not a big fan of it. Tachypnea, hypotension, altered mentation. I think it's a bit rough. But I'm not a big fan of news either. I mean, if you have good nurses, you may not need the muse or the news. But in the future, clearly, we will have very simple monitoring systems to allow us to monitor patients on the floor much better than today. We can monitor temperature from the distance. We can monitor heart rate from the distance. This is my friend Michael Pinsky using a smartphone to determine the oxygen saturation. Yes, it's possible from a smartphone. And of course, the heart rate and the breathing rate. So in the future, there will be percutaneous sensors. We will need less blood tests because we will just put a sensor under the skin, and we will have non-invasive assessments of blood flow. That's another paper that we wrote on intensive care in 2050 without central lines. We will have better tools to insert little catheters in the periphery. We will have other tools to evaluate tissue perfusion non-invasively, and this will change our world in the future. So what is the final aim after all in closing? If we think about it, very often in ICU patients, we do not focus on the heart. Very often, sometimes we do. Very often we focus harder on the peripheral cells. Because our patients, if they die, will die of multiple organ failure. And so ultimately we want to avoid hypotension, we want to maintain adequate tissue perfusion, we would like to see the lactate levels going down, and that's how we can use simple rules like the VIP rule or my more recent rule, Pavlov's. Arterial pressure, blood flow, blood volume. These are the basics, and they will remain the basics for the years to come. Thank you very much.